السلام عليكم ورحمة الله. سيمينارنا بعنوان cervicofacial necrotizing fasciitis, interdiction, infection of the skin and superficial fascia of the head and neck, and is commonly seen in diabetic and immunocompromised patients. It carries a high mortality rate from sepsis of the dead tissue in the affected area. The etiology factor of the cervicofacial necrotizing fasciitis include odontogenic infection, boring cuts, abrasion, peritoneal abscess, and boils of the head and neck reason surgery and trauma. The disease in the head and neck region can occur in two forms, behaving differently in different areas. The two areas are the craniofacial and the cervical. They involve the scalp and eyelids, where the disease is most commonly caused by trauma that may be minor, followed by infection. The organism most commonly isolated in this form of the disease are group A beta hemolytic streptococci, either alone or in combination with staphylococcus. Only few fatalities have been reported in this group. They later type classically involve the neck, and the majority of cases follow dental or oropharyngeal infection. As we see here in these pictures, infection with streptococci or staphylococci in the neck or cervical region. Necrotizing fasciitis is classified according to three different types, depending on the microbiological finding. Type 1 is polymicrobial infection produced by a combination of anaerobic and aerobic bacteria, whereas type 2 is a monomicrobial infection due to mainly to group hemolytic streptococci and least frequently to other streptococci and staphylococci. Type 3 is a monomicrobial infection caused by murine vibrio sepsis. Necrotizing fasciitis classification: type 1, 2, and 3. Type 1 polymicrobial, at least one anaerobic facultative plus or موجب موجودة أو غير موجودة. facultative يعني anaerobic، السالب أو الموجب facultative anaerobic. localization موجود localization بالترانج، البريوم والاكستريميتيز. type 2 monomicrobial group A, B, beta hemolytic streptococci and or other streptococci, staphylococci. Localization in the extremities. Type 3 murine vibrio localization in the extremities. Clinical features. The initial presentation is usually distinctly benign, although the extent of the tissue and facial destruction far extend the external evidence of infection. The rate of infection is usually rapid, and the patient often has a systemic disease such as diabetic mellitus, obesity, malnutrition, or alcoholism. The clinical features of this condition are usually manifested as smooth, tense, and shiny skin with no sharp demarcation in the area involved as the disease progresses. They pathognomonic signs of the condition include the dusky purplish discoloration of the skin, small purplish spots with all defined border formation of plaster or blay, subcutaneous fat. Sign and symptom: local or systemic, early or late. Early, local or systemic. Local skin myalgia or injury, erythema, warmness, tenderness, myalgia, hypersensitive skin, systemic pain out of proportion, swelling, fever. Late, hemolytic gas bio, necrosis, purple blue skin color, cryption, hyposthesia, sensory motor deficient, fever, hypotension, mental confusion, multi-organ failure. Etiology: the condition can result from dental abscess, gingivitis, pulpitis, sinus, pretonsillar and salivary gland infection, or from infection secondary to surgery, insect bite, or trauma. Dental infection are the most common etiology factor, followed by trauma, pretonsillar and pharyngeal abscesses, and osteoradionecrosis. They causative agents have classically been described as being group A beta hemolytic streptococci, staphylococci, and obligate anaerobic bacteria.
Risk factor: the mortality rate of cervicofacial necrotizing fasciitis approached 28%, and when associated with extension into the mediastinum and spaces, rates as high as 41% and 64% have been reported. Respectively, some of the reported predisposing factors associated with the development of cervicofacial necrotizing fasciitis include diabetes mellitus, poor dental hygiene, obesity, alcoholism, and immune-compromised states. Other risk factors: diabetes, chronic disease, immune suppressive drugs, malnutrition, age above 60 years, intravenous drugs misuse, peripheral vascular disease, renal failure, underlying malignancy, obesity. Pathophysiology: organisms spread from the subcutaneous tissue along the superficial and deep facial planes, presumably facilitated by bacterial enzymes and toxins. These deep infections cause vascular occlusion, ischemia, and tissue necrosis. Superficial nerves are damaged, producing the characteristic localized anesthesia. Important bacterial factors include surface protein expression and toxin production. M1 and M3 surface proteins, which increase the adherence of the streptococci to the tissue, also protect the bacteria against phagocytosis by neutrophils. Diagnosis: laboratory testing. Abnormal laboratory findings include an elevated white blood cell count, azotemia, abnormal conclusion profiles, and decreased platelet and fibrinogen level. Other laboratory findings such as elevated lactate and blood glucose levels, hypoglycemia, hypoalbumin anemia, and anemia are also commonly found. The sensitivity of these studies varies, although leukocytes and hyponatremia have been found to be predictive of necrotizing infection. Imaging study, plain radiography, ultrasonography, CT, and MRI have all been used to help diagnosis in NSTI. And this table for laboratory risk indicator for necrotizing fasciitis, like we see here in WBC, hemoglobin, sodium, creatinine, and glucose. Radiological examination should be requested as soon as possible in order to determine the extent of the disease and to correctly evaluate the airway of the patient. The CT enables us to see the information of subcutaneous gas and abscess, even though the CT image does not illustrate significant pathology. Its help guide surgical intervention. Like here, we see the CT and this picture of ultrasound. Other diagnostic tools like macroscopic and microscopic tools. Examination of a frozen section biopsy specimen from the compromised site that include deep fascia and possibly muscles has been recommended as a means to achieve aerial diagnosis of NSTI in patients. Like this picture. In picture D, we see extensive areas of necrosis with color hematoxylin eosine. In picture E, inflammation and necrosis involving adjacent muscles with hematoxylin eosine. Here we can see macrophage of necrotizing fasciitis showing the necrosis, center of the image, in the center.
Treatment for necrotizing fasciitis includes antibiotics, fluid replacement, nutrition, and daily debridement. To remove devitalized tissue, however, the cornerstone of treatment is debridement of the necrotic tissue and daily monitoring to assure adequate removal. Appropriate antibiotics and medical support are also important. Hyperbaric oxygen and intravenous immunoglobulin treatment decreases the mortality rate. The key in management is early recognition and early debridement. Of course, resuscitation is to be started immediately and empirical antibiotics consent. Even before the first surgical gesture, with lateral tailoring according to in vitro testing. Aggressive surgery implies to remove all non-viable tissue without concern for further reconstruction, preserving non-viable structure for a future cosmetic results, is responsible for continuous toxicity and infections progression beyond the healthy margins. Repeated debridement are required as lesion may progresses away from apparent viable limit of continuity of the neck fascia with mediastinum and thoracic wall structures favor progression toward these anatomic areas. Appropriate surgical management of deep neck infection is predicated on comprehensive understanding of the anatomy of the head and neck. All infected spaces should be readily opened and drained. One should take into account possible spreading to this space, and the picture we present clearly demonstrates the importance of adequately debridement fascia in these spaces. Reconstruction should be decided together by ENT surgeon in charge and the plastic surgeon, but early grafting should be delayed until bacteriological eradication. A good level of trust and communication between the two specialists will speed up the procedure. Mortality in cervicofacial fasciitis almost 40%. Different defect after aggressive debridement. Example of outcome of surgical treatment in patients. Complications. A. Superficial nerve are damaged, producing the characterized localized anesthesia. B. Sepsis induces with systemic toxicity. Hemorrhage caused by erosion of large vessels. Aesthetics, mutilation, mediastinus. This is our reference. Thanks everyone.